Okay. This is our last immunology lecture, all right? There's a few pieces I really want to hit on here, mainly the hypersensitivities we'll talk about. And then there'll be some review that I'll kind of move through relatively quickly. There's a couple areas we haven't discussed so far that I thought would be important. Again, just a reintroduction of primary versus secondary organs of the immune system, just for a reminder if you've forgotten. The anatomy of the lymph node, we haven't talked about this specifically, although I mentioned it earlier on the test. When I was talking about the different areas, I kind of mentioned follicle, medulla, paracortex. So the follicles are where B cells are. The paracortex is where T cells are. Medulla, you also could find T cells, but paracortex would be the best answer if they give you the answer. Sometimes they won't. They'll say follicle or medulla. So if you're given paracortex, that's where your T cells like to live. In DiGeorge syndrome, this area is underdeveloped, so it's an issue with T cells. It will also, this is the area that enlarges an immune response like Epstein-Barr or viral infections. This is the area that causes lymphadenopathy, is the enlargement of your paracortex, okay? And then the medulla region is really where your cords are packed. So like your vessels and things like that, your sinuses, where the flow happens in your lymph node. I would not put this to memory at this point in the game. This is lymph drainage and pathology. If you're like, I want to know, you can see it will give you the lymph nodes, the location of body drained, and the types of pathology associated. I don't think this would be worth it at this point in the game, except for maybe axillary, because it drains the breast for breast cancer, right? That would be maybe the only association I would lean into, although we could probably get there ourselves without knowing that. There's, I mean, some here, again, I would not commit this to memory, but you have it as reference. If you're reading about lymph node drainage and you're like, well, do they drain in a specific region for this condition? Yes, they probably do. The spleen itself, our other organ, also has a follicle, also has this marginal zone. Important things to know, the periarteriolar lymphatic sheath is where B cells live. So you could think about in the white pulp. The follicle, again, is where B cells are. This is also in the white pulp. So follicle is where B cells are always in the spleen and the lymph node, right? And then the marginal zone is where you can have kind of other cells potentially. This is kind of where the communication zone is between the white pulp and the red pulp of a spleen. Think about the red pulp as where your blood cells are being broken down, your erythrocytes, versus the white pulp as part of your immune system. Okay. Oops, sorry. After a spleen is removed, I'm not going to play this video, but the only thing I want you to recognize is that you will see decreased IgM, you'll see decreased complement activation. You're going to have increased susceptibility then to encapsulated organisms because you're going to have less ability to opsonize, less ability to target an organism that's encapsulated. You also could see some of these microscopic findings, Howell jelly bodies, and target cells in particular. So this is really the only time where I see questions asked about a post-spleen or a splenectomy is really to try to get you to identify an encapsulated organism as being a cause of a condition, so you're at increased risk, or if they're talking about these, like what would be the likely histologic finding, and then list some of these specific names. I'm not going to talk much about your thymus. I don't think they'll ask you much, except for it's where T cells mature. The one kind of pathologic connection is a thymoma is associated with myasthenia gravis. So that would be a helpful potential connection between those two pathologies. Okay. When it comes to innate and adaptive immunity, we've talked a little bit about the cell players in each, but I did want to just remind us about a couple things that we haven't discussed specifically. When it comes to innate immunity, protein secretion, remember that all of our skin surface proteins, like our defensins, our lysozymes, even CRP, can be involved in the innate immune system. So don't forget about that like epithelial layer of protection that is part of innate immunity. And then in regards to pathogen recognition, I don't think you'll need to know the specific in and outs of like what type of toll-like receptor, what PAMP is being recognized. But in general, understand that innate immunity, there is binding that's happening. There is recognition that a pathogen is present, but it's not recognizing that this is Staph aureus. It's recognizing this is a bacteria, right? So it's a general recognition that it's not self. Versus adaptive immunity, we get that specific memory, that specific recognition that this is Staph aureus infection. And every time the body sees that again, it will have a specific binding ability once it's seen that infection once before. And we kind of remember our memory cells, our B's and our T's. The only cell type we haven't discussed specifically was natural killer cells. I like kind of breezed by it when we talked about our cell types last time. So I just wanted to remind us that this is a lymphocyte member of the innate immune system, but it comes from that lymphoid progenitor side. So it comes from the same backbone, the same back cell as your T cells and your B cells, but it's part of the innate immune system. So that's different. Its action, it has porphyrin, which is essentially, you could think about as like a pore that can jab into a cell, and then it releases granzymes that break down the cell types. It'll induce programmed cell death, apoptosis, specifically for cells that are virally infected or anti-tumor cells. It will be induced to kill when there's a non-specific activation on the target cell. So when the cell itself is targeted, macrophages can do this, opsonization via antibodies can do this. When the cell is targeted as being infected or having a tumor growing, that's when a natural killer cell will then be able to identify and utilize its porphyrin and granzymes. It also can be induced to kill if there's an absence of an inhibitory signal, so absence of MHC1 on the target cell surface. So it's either or. It's when it's targeted to be killed or when there's not an absence inhibiting it from killing. Essentially, either or could occur. You also can see an antibody-dependent cell-mediated cytotoxicity. I wouldn't worry as much about this mechanism. I would more focus on this innate mechanism. This is more commonly discussed for natural killer cells. And then these are specifically the cytokines that induce its activity. Interleukin 2 and 12, interferon alpha and beta. Okay. This is where I want to spend a good chunk of our time in this section, is just reminding us of our hypersensitivity reactions. They're commonly tested on. You can remember them as your A, B, C, and Ds. A being type 1, anaphylactic or atopic. B being antibody mediated. C being an immune complex, and D or 4 being your delayed. Remember, A, B, and C deal with antibodies. So while 2 or B is the only one that's called antibody mediated, both anaphylactic or atopic, antibody mediated, and immune complex all are dealing in the world of antibodies. The only one that isn't is delayed. Okay. And we'll look at them specifically and give some examples. So type 1 hypersensitivity is typically given as anaphylactic, although atopic is an example of type 1 hypersensitivity. So atopy is an example of a type 1 hypersensitivity, not of delayed hypersensitivity. That's commonly asked. They commonly try to pull you there. So our atopic dermatitis, our asthma, our eczema, that's atopic in nature, our allergic rhinitis. These could be examples of a type 1 hypersensitivity. Anaphylaxis is our classic picture, but it's all utilizing the same mechanism. It's just the severity of the response, right? So this is our first and fast. There's 2 phases. The immediate phase happens in minutes, and then there's a prolonged phase for type 1 hypersensitivity. The antigen will cross-link or bind to IgG immunoglobulin, IgE, on pre-sensitized mast cells. These means mast cells that they have identified this antigen, they know it, and they're ready, right? This is why the first time, if you have a peanut allergy, you would not necessarily have an anaphylactic response. It's the second time that you're exposed to it, once your mast cells are pre-sensitized to that allergen, that you could have true anaphylaxis. So oftentimes you could have someone say, but I had shellfish before and I was fine. And it was the second time I had it that I got like this big swelling. It's because your body then had this pre-sensitization to mast cells that it never had before in the past. And so that's where you get this reaction. Degranulation will then occur from our mast cells, which when mast cells degranulate, they release histamine, tryptase, and leukotriene, but histamine is the one that causes a lot of the stuff. The late phase, the hours after, you'll have chemokines that are attracting more inflammatory cells, specifically eosinophils, because we're dealing in the nature of IgE antibodies. And that's going to deal with inflammation as well as tissue damage, because eosinophils, if we remember, they have granulocytes, they have the granules that can cause, they're the bright pink ones, and they can cause a lot of local damage when they are released from eosinophils. And so we can continue to have kind of this cycle going on and on and on until the antigen is not there anymore. Anaphylaxis, allergic asthma, allergic rhinitis, all those atopy conditions are examples of type 1 hypersensitivity reactions. Okay. The biggest thing here is they'll give you a question asking about allergic rhinitis, and they'll try to get you to say it's delayed. And so just remember, it's type 1. If it's dealing with IgE, that's an antibody. It's type 1. It's antibody-mediated IgE allergy. Our type 2 hypersensitivity is antibody-mediated. Now, again, like I said, all of them have antibodies, but antibody-mediated, meaning antibodies are going to be the main kind of actor here. Antibodies in this type of hypersensitivity will bind to the cell surface antigen or to the extracellular membrane. So that's the kicker here. The antigen is in the cell itself. It's not just secreting around in systemic circulation. It's actually on the cell. So the antibody will bind to the antigen on the cell membrane, or it'll bind to the cell membrane itself. The antibody will. This leads to cellular destruction, inflammation, dysfunction. There's 3 kinds. So cellular dysfunction, we'll look at like each of these like areas of damage. Cellular destruction, the cell is opsonized by the antibody. Opsonized meaning it's coated, right? The antibody is bound all throughout the cell. This is going to lead to phagocytosis, activation of complement, and natural killer cell killing. All of them essentially trying to eliminate the cell. So autoimmune hemolytic anemia, immune thrombocytopenia, transfusion reactions, hemolytic disease of the newborn, all of these are examples of the cellular destruction that can happen from in a type 2 hypersensitivity, okay? From the antibody opsonizing the cell and then targeting it for destruction by either phagocytosis, complement, or natural killer cells, okay? Inflammation, binding to antibody to cell surface. So the antibody binds to the cell surface directly. It's going to cause inflammation, specifically via complement. The system and the FC receptor mediated inflammation. FC receptor mediated just means binding to the FC component of the antibody. Okay. Goodpasture syndrome, rheumatic fever, and transplant rejection are examples of this inflammatory response seen in type 2 hypersensitivity. Okay. Last one is our dysfunction, cellular dysfunction. Antibodies are binding to cell surface receptors this time. So first was opsonization. Second was it was binding to the antibody cell surface. Third, this one's binding to cell surface receptors, the antibody. This could lead to abnormal blockage of those cell receptors to whatever they're supposed to bind, and then downstream effects from that, right? If we're blocking with antibodies, still targeting and tagging the cell, all the things we've discussed before, but now we're also blocking whatever the action was supposed to happen from that receptor. So myasthenia gravis, Graves' disease, and pemphigus vulgaris are examples of cellular dysfunction in a type 2 hypersensitivity. Okay, so lots of options here. They're probably not going to make you specify what type, but they might give you some type of description here. And so I want you to recognize all 3 of these are all type 2 hypersensitivities. That's why I broke them down. Again, kicker is the antibody is binding to the cell surface itself or the receptor on the cell surface. The antigen's not floating around systemically. Okay. Our type 3 hypersensitivity, also dealing with antibodies and as an immune complex. Now we have the combo of 3 things that get stuck together in our systemic circulation: the antigen, the antibody, specifically IgG, and complement. All 3 things are bound together in this clump, and they're floating through our circulation. This is an example of an antigen that's not on a cell surface. This is an antigen that's freely moving through the body. This is going to attract a neutrophil and release lysosomal enzymes to try to destroy said thing. And you can see these examples with lupus, rheumatoid arthritis, reactive arthritis, polyarteritis nodosa, post-strep glomerulonephritis, IgA vasculitis. As you can see, a lot of itises, right? A lot of inflammatory conditions that are autoreactive, autoimmune in nature. You're going to see fever, potentially itching, joint pain, proteinuria, especially if it's dealing with the kidney, like a glomerulonephritis, lymphadenopathy, specifically 1 to 2 weeks post antibody exposure, antigen exposure, because it takes time for the body to identify it, create antibodies, and then bind with these complexes and then get stuck somewhere, right? And that's what causes the symptoms. We can see serum sickness. That's when antibody antigen complexes deposit into tissues. Complement is activated within that tissue then, and tissue damage and inflammation can occur. That's how we see a lot of the joint pain or maybe the rash. Versus an arthritis reaction, this is a local subacute inflammation, immune reaction. This could be with a booster vaccine, local edema, necrosis, complement activation. But essentially what happens when we get vaccinated and we get pain in that site, that's a local type 3 hypersensitivity reaction, arthritis reaction. Okay. If these things get stuck in the kidney, that gives us a glomerulonephritis, right? We get damage to the basement membrane because we have these antigen antibody complexes that can't get through the whole filtration process because they're too big. And so they pool there where the blood is, and then the tissue, we start to attack it with our inflammatory neutrophils and complement, and we destroy the actual tissue in the kidney. We destroy some of those cells. That's how we get proteinuria. So all these conditions, if you hear proteinuria, maybe think about type 3 hypersensitivity complexes. It won't always be true, but it could lead you down the right path. Our last one is not antibody involved. No antibodies. That's how it's different. It's delayed. There's 2 mechanisms that it can occur: direct cell cytotoxicity or inflammatory reaction. In direct cell cytotoxicity, this is where you have your CD8 killer cells are killing off targeted cells. For whatever the reason is, they've been targeted, they're killed off. This is a direct cell death, right? Direct cell cytotoxicity. Inflammatory response is dealing with our CD4 T cells, recognizing antigen, releasing inflammation-inducing cytokines, causing inflammation or cell damage or destruction because of T helper cells, of cytokine cells. As you can see here, we're not dealing with B cells with type 4 hypersensitivity. We're dealing with T cells. We're not dealing with antibodies. We're dealing with T cells. So if they asked you what type of cell mediates a type 1 hypersensitivity, B cells would be your answer, right? If they give you B cells, Th1, Th2, and antibodies, antibodies aren't a cell, right? B cells are the cell type. It's antibody mediated. For type 4, it'd be T cells, and it could be T helper or T killer, depending on the type, depending on the response. If it's direct cell cytotoxicity, T killer, T8 or CD8s. If it's more of an inflammatory response, a CD4. They likely aren't going to make you specify. They're going to just ask you what's the cell type that governs a type 4 hypersensitivity, a delayed hypersensitivity. And they'll want you to choose antibodies, B cells, et cetera, choose T cells. That's its big differentiator. Your examples would be contact dermatitis. That's probably your best example. Or graft versus host disease would be another good example. These would be 2 common examples seen. But if there's an antibody at all, it is not a type 4 hypersensitivity. Yes.
So with the type 4 and type 2 with the grafts, and the transplant, like all I've seen so far, the difference is like 1 is a 2 plus hyper, 2 is there like 1 differentiation.
Yeah, so a transplant rejection is the body's actually created antibodies against the transplant itself. And so it's tagging the transplant with antibodies. And so you're having antibodies binding to the actual cell surface of the transplant. That's like the transplant rejection reaction. Versus graft versus host disease, the body isn't creating antibodies to said graft. The graft is causing an inflammatory reaction with CD4 helper cells. So our T helper cells are producing inflammatory cytokines. So our innate immune system might then start targeting the graft via macrophages, neutrophils, natural killer cells, but we're not getting an antibody response. typically, once you have a transplant rejection, that has to be removed. But a graft versus host, you might be able to stop the inflammatory process and retain the graft. Because the graft, the body is viewing the graft as like a foreign invader that's causing inflammation, but it hasn't targeted it as not self yet. Versus the transplant rejection, at that point, the body's targeted that as not self and has produced antibodies to that. Once that happens, you can only do immunosuppression at that point, and that could be dangerous depending on how much you have to immunosuppress. Most people have immunosuppression on board with a transplant, but it's to try to prevent the immune system from tagging it as not self and producing antibodies. Yeah, it's a great question. Yes, yeah. They'll probably have a condition that's part of your case, and they'll ask you what hypersensitivity it is or what cell type mediates the hypersensitivity. And they could give you like the hypersensitivity type 2 and T cells, hypersensitivity type 2, B cells, kind of do those dual questions that NPLEX loves, where they have multiple things you have to think through. But most of the time it's going to be, they'll give you a condition state, and they'll ask you to match it to the cell mediation as well as the hypersensitivity type or the antibody type and the hypersensitivity type. Yeah, excellent. And yes, I will. I saw your question online. I'm going to get to complement here in a second. Atopic dermatitis. Yeah, absolutely. Great. All right. I'm going to get to complement next, I think. And then I think that will help. Okay, I don't have complement next. I'll do complement next and we'll come back. We'll go back to these. Okay, so complement. Since I've mentioned it, I will talk about complement and then we'll go back to what the previous slides were. So complement, it's simple. It's a part of your innate immune system. It's synthesized in the liver. It's plasma proteins. It's involved in innate immunity and inflammation. The big one I want you to know is the MAC attack. Membrane attack complex. This is a big one to defend against gram-negative bacteria in particular. Okay. Complement can be activated via IgG or IgM mediated. That's the classic pathway of activation. These activation pathways just depend on the type of complement proteins that are essentially turned on or upregulated. There's complement proteins there's tens, 20s, maybe hundreds. They're all labeled with C, some number, and some letter, okay? I don't care that you know all those specificities for this test at this point. There may be some questions that ask for a specific type of complement protein, but they'll be very few and far between. It's not worth your brain power at this point in the game. But know that there's different pathways that can be activated by complement, regardless. Classic is using antibodies. Alternative is microbial surface molecules, so actually like microbial components on their surface. Think capsule, think endotoxins or exotoxins. Think about things that actually can live on the surface of a microbe. And then leptin, which are sugars that are also glycoproteins on a microbe surface. These are generalized structures. They aren't specifically identifying the pathogen because remember, this is part of the innate immune system. But any of these three options can activate complement. Complement will be pro-inflammatory. And if it utilizes the MAC, the membrane attack complex, it can actually perforate a cell itself, much like a natural killer cell can. That's what I'd want you to really know about complement. If you're trying to learn a little bit more specifics about the types, this is an example of the different functions based off of what the complement protein is. You can see the example C meaning complement, the number and the letter. I would not necessarily focus on learning these now. If you really want to, these would be the only ones I'd commit to memory. C3b is involved with opsonization, so IgG antibodies. This will increase phagocytosis. Cytolysis, so destruction of the cell, is from that C5b9, which is the MAC attack or the MAC complex. Anaphylaxis, you can see all of these A's, they all have anaphylaxis, right? They all have the A on them. That's how I remember them. So 3, 4, and 5 with the A, or helping neutrophils move to the site of the crime, essentially C5A versus C5b is dealing with that boring a hole, the MAC attack. That's all I would know about complement. Okay, so if you know these pieces, you know enough for complement for the purposes of this test, but it is a part of the innate immune system. Okay, going back to where we were. All right. So T cell differentiation, I don't have a lot to say here. This is really just a reminder. And also if you learn better this way, it's to kind of summarize things we've talked about. So this shows you the helper T cells that we know, Th1, 2, 17, and Treg. These are cytokines that will stimulate their release or stimulate their differentiation. So for example, we'll just go through one. Th1, interferon gamma and IL-12 will encourage more Th1 to be produced versus IL-4 and 10 will decrease Th1 production. You can see that some of them, interferon gamma promotes Th1, but downregulates Th2. So you can start to see kind of the immune response that this cytokine is going to promote, a response to an intracellular pathogen, right? And then what do these cells produce themselves? Th1 is going to secrete more interferon gamma, so a positive feedback loop locally, as well as IL-2 pro-inflammatory. And what did they activate? They activate macrophages and cytotoxic T cells. So if you're more of like a flowchart person like me, this could be a helpful slide to kind of summarize a lot of your cytokines and the T cells that they are influencing. Yeah. They're both inflammatory, but think of Th1 is stimulating a response to things inside of a cell. So bacteria that are intracellular or viruses that are intracellular versus Th2 is going to be your antigens that are free floating outside of cells. So your allergy response or your parasite or Helminth response typically, but both are inflammatory in nature. Treg is your anti-inflammatory T helper cell. Treg is going to balance both of Th1, Th2, Th17. T is your, you could say your attenuator of your T cells. This kind of just talks about the relationship between the two. I don't think this is as important to know, but if you're having trouble kind of understanding how macrophages and T cells are relating to one another, it's all based off of the binding molecules. Cytotoxic Ts, we already talked about those. And regulatory Ts, we've talked about those. And T cell activation, we've talked about that. Okay, great. All right. Antibody structure and function. The only thing I want to say about this is the general component that's bound to the cell membrane initially of your B cell is the Fc component. The part that binds to the antigen is the Fab component, the fragment antigen binding component. So this is the antigen binding site. These are the sites that are going to be specific for whatever antigen it's binding to versus Fc is going to be consistent because that's the part that was bound to the actual B cell initially. The Fc region is what decides if it's going to be IgM or IgG or what class of antibody it's going to be. It's going to be related to this Fc component here. Fab determines the type of antigen it's going to bind to. Okay. Heavy chain includes Fab and Fc. It's the long chain. The light chain, this short chain, is only to the Fab region. Okay, so if they mention light chain versus heavy chain, the light chain is the short blue component here. It's smaller and it only is associated with the antigen that it's binding to. The heavy chain is this longer component here, and it's the antigen binding as well as the Fc portion that's actually bound initially to the plasma cell, the B cell. The types we've talked about already. We start at IgM or IgD. IgD does exist. We just don't have a lot of function about it. And it'll seroconvert in this order, A, G, E, H. Okay. So we'll start with IgM. We then go to A. We then go to G. We then go to E, depending on what we're needing. But that's the seroconversion order that takes place. IgD, we don't know what it does exactly. It's found on the surface of B cells and in serum. Sure, in the next 2 years, we'll know more, but NPLEX is 2 years old. So for now, know that it exists. It could be on your test as an option, but we don't exactly know the functionality. IgM is the first one to come to the scene. It's the first responder to an antigen. It can help fix complement, meaning activate complement or help it bind to an antigen. It is also has multiple binding sites. I don't know if I have a picture. Essentially almost looks like a spider. It has multiple binding sites. It's the largest antibody, the largest immunoglobulin, IgM. IgG is the main antibody in a secondary response to an antigen. So if you see antigen a second time, IgG is going to be your big one that's produced. It's the most abundant in serum. So it's the most common one we'd find if we test for something. It can help with opsonization. So that's a new function. It can also neutralize toxins and neutralize viruses. It's the only isotype that will cross the placenta. So it can provide some passive immunity. So if asked about passive immunity or placental transplant or placental immune system or infant immunity, IgG is your answer. IgA is our mucous membrane protector. It prevents attachment of bacteria and viruses at the mucous membranes. Doesn't do anything with complement. It can cross epithelial cells. It can be produced by Peyer's patches in the GI, so really helpful for gut infection. So a lot of mucosa in the gut, makes sense. It also can be released in any of our secretions and breast milk. And it's the most abundantly produced overall, but it's less populated in the serum, right? It's produced from mucus. It's not necessarily produced to circulate in the blood as a whole. It's produced more locally, but it's the largest amount that's produced. And then IgE, they bind to mast cells and basophils, our allergic and our parasitic response. They can cross-linked with allergens. There are type 1 hypersensitivity mediator. And then I already mentioned the parasite component with our eosinophils. Talk about complement. Passive versus active immunity. Passive means you receive pre-formed antibodies. This is fast, but it's short. It's just the span of the antibody that's present. So like IgA in breast milk, maternal IgG crossing the placenta, monoclonal antibodies given to people. Once the antibodies are used, you haven't produced them, so they're gone. It's passive. Active antibodies, your exposure to the antigen exogenously, it's slower but longer lasting. So natural infection vaccines or toxoids. So this is where we get into our immunization conversation. Vaccination. I would only know the way the body responds. You don't necessarily need to be able to match it to what type of virus or component is given. That's more of NPLEX II. I did give you some examples just to help you like connect it in your brain to what vaccines you've maybe experienced before. But live attenuated, an example that may connect with you is like influenza is a live attenuated, or MMR can be live attenuated, varicella. With MMR and varicella, these are often frozen, right, to allow to maintain their efficacy and their use. Microorganisms are prepared as non-pathogenic. They could, in rare occasions, revert to their virulent form. That's why it's contraindicated if you're immunodeficient or pregnant for these vaccines, typically. Essentially, it will cause both a cellular and a humoral response. So you'll have strong lifelong immunity. So that's why they're favorable, but they aren't for everyone, okay? Cellular, meaning you're going to have cell responses and you're going to have a humoral response, so an antibody response. Because you'll create antibodies and you'll create cell memory. Killed or inactivated, it's typically the pathogens killed by heat or by chemicals in some instances. You'll see the epitope structure of the surface antigens will be retained. You'll have a humoral response. So it's safer, but it's weaker. So therefore boosters are needed. This is your Hep A is probably the most common. This is your injectable influenza, typhoid, polio. These are all killed or inactivated. Subunit, recombinant, polysaccharide, conjugate, all of these use antigens that are from said bacterial or viral component that stimulate the immune system. They'll target specific components of those antigens. It's less of a severe reaction because it's not the full virus, live or dead, but it's more expensive and a weaker immune response. This is your Hep B. This would be your meningitis vaccines, your pneumonia vaccines. Both these are pneumonia, meningitis for these two. Shingles vaccine. They're all recombinant polysaccharide conjugate subunit. These processes, all using antigen. Your toxoid is taking a bacterial toxin that has intact receptor binding sites. This will stimulate an antibody response, but you can't have disease. It protects against specifically the bacterial toxins. The antitoxin level will decrease over time. That's why you need boosters and your tetanus vaccine or diphtheria vaccines. So your TD or Tdap are your most common toxoid. And then mRNA. These are using fat nanoparticles delivering mRNA. This will cause the cell to synthesize foreign proteins like the spike protein in SARS-CoV-2. This will give both a cellular and humoral response, kind of like the live attenuated vaccine that we had at the beginning. There's high efficacy, so it's like going to be that strong response, right? Like we got with the live one, but this one is safe in pregnancy in that there's no seroconversion possible. So that's why there's been more research on mRNA as of late. There's lots more local and transient systemic reactions though, because it is telling our cells to synthesize a foreign product. So that's where you can see common like side effects that are pretty significant or severe, as well as the risk factors for some of these heart conditions like myocarditis or pericarditis. They're not going to ask you about why or when to use them. They're going to only ask about the immune response to them. They're not going to want your opinions on them. They just want to know what the body does in response. So if you're able to connect the name to how the immune system will respond, cellular, humoral, or both, that will be plenty for those vaccines. Okay. The last section is kind of combining some immunology with some immunopath. So I did want to mention a few pieces that are important to note. We haven't talked specifically about our HLA subtypes associated with disease. So this is your slide. These are the ones I would try to know if you don't have them already. So your B27, so HLA B27 subtype is associated with psoriatic arthritis, ankylosing spondylitis, IBD, arthritis, and reactive arthritis. So PAIR is your mnemonic. Celiac disease is HLA DQ2 or DQ8. So I ate too much gluten at Dairy Queen. Fair. Dr. 3 or DR3 is going to be diabetes type 1. It's also lupus, as well as a bunch of other stuff. Graves, Hashimoto's, Addison's disease. It's kind of a big combo of stuff. I don't really find these mnemonics helpful at all. Maybe this one, SL3 for SLA for lupus, but not this. This one confuses me more than anything. So, but this is our DR3 HLA diseases. And then DR4 is rheumatoid arthritis, also diabetes type 1 and Addison's disease as well. So there's 4 walls in one room. So rheumatoid arthritis is the one that's special for DR4, given that type 1 diabetes gets both and Addison's disease gets both. If you know these HLA subtypes, that would be plenty for this test. If you don't, and you have time to commit them to memory, great. They will be on the exam in some way, shape, or form. Not all of them, but some combination of some of them. Autoantibodies, this is not a comprehensive list, nor do I think this is a list that you should necessarily try to commit to memory. But if you're feeling confused about autoantibodies associated with disease, this gives you some of the big players involved. This is the antibody in question, and this is the disease in question. I, at this point, don't encourage you to try to put this to memory because it's just a lot, but it can kind of help you understand the pathology or the pathogenesis of the condition. Myasthenia gravis, there's an antibody to the post-synaptic acetylcholine receptor. So post-synaptic, the receptor on the actual effector cell or effector organ that binds acetylcholine. That's what's being targeted. So it's essentially destroying the receptor that binds acetylcholine that causes the pathogenesis of myasthenia gravis. So that's where these could be helpful, is if you're having trouble like understanding the pathology of a condition. Sometimes these autoantibodies can help you, but just a straight memorization, I don't think would be helpful at this point, unless you already have them there. Like Rowe and Law, like I always have that, that's like stuck in my brain from Sjogren's syndrome. But some of these other ones, maybe not so much. Some immune pathologies I listed here. Not all of these are going to come up. Some of them might. X-linked or Bruton's A-gamma globulinemia. This is an X-linked recessive condition that that's really all I would connect here, honestly. You have no B cell maturation. That's the kicker in this condition. Selective IgA deficiency, it's idiopathic, and it's the most common primary immunodeficiency. That's what I would have with this one. That would be my memory pathway here. You will see less IgA. Common variable immunodeficiency, you'll have defects in B cell differentiation. So autoimmunity is going to be at an increased risk. I'm just trying to pull the most important thing I would know of these if you want to know anything. Chronic mucocutaneous candidiasis is a T cell dysfunction. So cell-mediated immunity is effective. So essentially a persistent candida infection of the skin and mucous membranes. Hence the name, right? Chronic candida. Or severe combined immunodeficiency, any combo of any type of immunodeficiency state. There's multiple different types. I don't often see them test you on this. I have seen chronic mucocutaneous candidiasis. I've seen selective IgA on your exam before, those two. And my last piece of the puzzle today is going to kind of lead us into our micro discussion that we'll have this week. But it's talking about if you have an immunodeficiency, what bug is more likely to get you, okay, in these categories. So if you're low in T cells, and you have a bacterial infection, you're more likely to get sepsis versus if you're low in B cells, encapsulated bacteria, right? Because B cells produce antibodies. Antibodies can opsonize capsules, encapsulated bacteria. If we don't have B cells, we can't opsonize, meaning that encapsulated bacteria can live free. So a good mnemonic for encapsulated bacteria is please shine my skis, Pseudomonas, Strep pneumoniae, H flu, H flu B, Neisseria meningitidis, E. coli, Salmonella, Klebsiella, and Group B strep. This list of encapsulated bacteria that have capsules, that would be a good list to put to memory. Because anytime you're getting a question about opsonization, about virulence factors, about cells that can evade macrophages, about immunodeficient states and infections that would be more likely, this list would be a good list to pull from for an answer. If you have the inability to produce granulocytes or you have a low amount, these are the bacteria that could potentially be more infecting of you, I guess, staph, Pseudomonas. Those would be the two I'd know. I don't know if that's that important. I honestly wouldn't care. I wouldn't even worry about these two categories. I would know this. Know your encapsulated bacteria of this list. That would be the most important, high yield. Your viral infections, low T cells could cause a lot of issues with viruses. Epstein-Barr, Bacillus zoster, cytomegalovirus, low B cells, more likely with polio. But in general, if you don't have adequate T cells, viruses could be potentially more infective. So you'd be wanting to be concerned about your chronic viral illnesses or actually being symptomatic from a viral infection that maybe normally wouldn't cause symptoms in a healthy person. And then fungal parasitic infections, I honestly would not put too much time. And when we do our microsection, we're not going to spend a lot of time. I'll just tell you a few that we want to know. So I wouldn't pay attention to this now. We'll look at a few fungus and a few parasites that you could pay attention to on your test when we do our microsection. Okay. I see a lot of questions in the chat, so I want to make sure. Okay. Encapsulated is different than gram-positive LPS cell wall. Yes, encapsulated is different than gram-positive LPS cell wall. Encapsulated means that there's just a capsule that's covering. Gram-positive LPS cell wall is actually a virulence factor. It's a protein coming off of the cell wall itself versus a capsule will go around the cell wall, whether it's gram-positive or gram-negative. Are there multiple types of vaccines for some viruses? Yes, like influenza has two different, they have a live attenuated and they have an IM virus. So yes, there are multiple types of vaccines for some viruses. Atopic dermatitis compared to anaphylaxis. Yes, both of them cause a type 1 hypersensitivity. Hyperacute transplant is type transplant rejection. Yes, the assembly gets confused about all of them and says all of them are everything. Complement, I talked about that. Are all other dermatitis besides contact type 1 hypersensitivity? If a dermatitis is atopic in nature, you could say it's type 1. If it's not, I would not state that's true, but your atopic, your allergy-based dermatitis, you could say are type 1. Your contact dermatitis, you could say it's type 4. Your irritant dermatitis, I would lean into type 4. Okay, I think those were all. Great. All right, questions in the room, in the house. You know so much already. You could stop studying now and you'll be fine. Okay, I encourage you to do that. But I did want to check with people and see. I have a day of path essentially and a day of micro this week. Would you prefer to do micro tomorrow and path Thursday, or path tomorrow and micro Thursday? Micro tomorrow. Does that feel okay for everyone in the room? Is anyone dying to have pathology tomorrow? No. Okay. Anyone online dying to have pathology tomorrow, or is it okay for me to switch it to micro first? Micro tomorrow. Great. Thanks. Okay. I'm going to take that as a yes. Okay. So we will do I will just swap the days. So micro will be tomorrow. Then we'll finish up path on Thursday. I would encourage you to bring pens, paper tomorrow with you to write on if you don't normally. Okay. Thank you. Powered through. Got done early. Thanks, folks. I'll post these recordings either within the next hour or tonight when I get home.
Thank you.
Thanks.
Thank you.